Hello, everyone. Today, we'll talk about acid-base disorders. That's another video. And this is Dr. Kamal. Acid-base disorders intimidate almost every medical student. The challenging part is not memorizing an algorithm. The real difficulty is figuring out why the disorder is happening. It's easy to label something as metabolic acidosis or alkalosis, but it's harder to identify the underlying cause and how to fix it. Unlike other condition, treatments is always not straightforward, like hypokalemia, give potassium. No, it doesn't work like this. So if someone is having alkalosis, we don't just give acid, or someone having acidosis, we don't just give bicarb, right? Sometimes we give sodium bicarb in severe acidosis, like if the pH is like less than 7.1, but even this is controversial and we don't have a good data about it. And usually it's just a temporary bridge till we treat the cause or consider dialysis in that case, right? So we know acidosis is more like dangerous than alkalosis. It can cause to cardiac arrest, it can cause tissue hypoxia, electrolyte disbalances, mitochondrial dysfunction, and so on. And also, even alkalosis is not harmless either. It carries its own risk of different complications, right? So today we will try to focus on the underlying cause and the pathophysiology of different disorders, and how can we find a practical way to really understand what's going on. So let's get started. So we'll talk about acid-base disorders and compensation. So let's just first review different normal values. So first of all, we have the normal pH. The normal range is between 735 to 7.45. If it's below than this, then it's acidosis. If it's above than this, then it's alkalosis, right? Then we have the PaCO2, which is the CO2 that's the lung is responsible for excretion, which is the normal range again between 35 to 45, average of 40. If we have too much CO2 above 45, then this is respiratory acidosis. If we have the PaCO2 less than 35, then it's respiratory alkalosis. When it comes to bicarb, usually the kidney is responsible for regulating the bicarb. The normal bicarb range between 22 to 26, let's say average of 24. If it's less than 22, then it's metabolic acidosis. If it's above 26 or 28, it's metabolic alkalosis. So we have the basic cis, which is mainly bicarb. So if it's is dropping more than 2 points, we consider that acidosis. If it's increasing more than 2 points, that's consistent with alkalosis, right? Then we have the nine gap, which will understand what's exactly in a nine gap. But for now, the normal range of the nine gap is 8 to 12. If it's more than 12, we call it elevated a nine gap. So the algorithm we'll try to follow today is 6 steps. So the first step is to assess the pH. We want to know if this is acidosis or if this is alkalosis. Again, the normal range between 7.35 to 7.45. If it's below this, it's acidemia. If it's above this, it's alkalemia. If it's in the range, of course, it's normal, right? So if we have acidemia and we have high CO2, that's respiratory acidosis. If we have acidemia and low HCO3, that's metabolic acidosis. On the other side, if we have alkalemia with low CO2, that's respiratory. If we have alkalemia with high bicarb, then that's metabolic alkalosis. The next step, number 3, is check compensation, whether it's respiratory or metabolic alkalosis or acidosis, there's compensation. If the compensation is outside the expected range, we call it mixed disorder, right? Then, in case of its metabolic acidosis, we'll calculate the 9 gap, and the 9 gap is the cations minus the anions, so sodium minus chloride plus bicarb. And again, the normal range is between 8 to 12. If it's more than 12, we call it high anion gap metabolic acidosis, right? If it's 8 and 12 and it's metabolic acidosis, then we call it normal anion gap metabolic acidosis, right? Then this only applies if it's high anion gap metabolic acidosis. We calculate something delta ratio, and delta ratio is mainly to try to detect any hidden concurrent metabolic disorder. So you can have high metabolic acidosis, high anion gap metabolic acidosis with metabolic alkalosis, or high anion gap metabolic acidosis with normal anion gap metabolic acidosis. And the way to figure this out, we calculate the delta ratio. Then number 6 is the most important. All these steps is trying to identify the acid-base disorder to be able to identify the cause and treat it. And this is the real treatment of the acidosis. If you tell, or sorry, the acid-base disorder. If you tell me someone is having respiratory acidosis, I don't care about the respiratory acidosis itself. It's usually a red flag of the body about the etiology. So if it's COPD, if it's opioid overdose, we need to correct that, right? Then we have here, that's just a summary of the compensation formulas. We'll talk about each one separately. So number 1, we have respiratory acidosis. So from acidosis, we know that the pH less than 7.35. And if it's respiratory, then the problem is in the CO2. So here, if the CO2 above 45 and this acidosis, we call it respiratory acidosis. What's the compensation? If it's respiratory, the acidosis would be metabolic, renal, right? If it's acidosis, we want to keep the bicarb. The renal do bicarb retention to try to compensate for the high acidosis. And usually the renal compensation is slow. So that's why in any renal compensation, we'll talk about acute and chronic, because the kidney takes time to compensate. So in the respiratory acidosis, if we have 10 points increase in the CO2, if it's acute, the kidney will try to compensate by retaining 1 milli equivalent of bicarb. On the chronic part, it will be more. So if we have 10-point increase in the CO2, the kidney will retain around 3.5 of bicarb. So acutely, if there's 10-point increase in the CO2, this will drop the pH by 0.08. But chronically, because the metabolic compensation is better, the drop in the pH will be less. So for example, in the chronic state, 10-point increase in the CO2 will drop the pH only 0.03 instead of 0.08. The second part is respiratory alkalosis. Alkalosis means we have the pH more than 7.45. If it's respiratory, that means the problem is in the CO2, and the CO2 is less than 35. The compensation here will be renal compensation, and it will be HCO3 excretion to try to compensate for the alkalosis. So we try to do some kind of acidosis here. And again, if it's renal, then it's slow. So we have acute compensation and chronic compensation. If we have respiratory alkalosis and the CO2 drop 10 points at the acute state, the HCO3 will drop by 2 points. And if in the chronic state, the compensation is better. So 10-point decrease in the CO2 will cause retention, or sorry, excretion of bicarb by 5 points. And the bicarb, it doesn't keep dropping. Usually it stays at the 15 range. So if it's like 24 initially, it will keep dropping till it reach the 15, and that's usually the full renal response or full renal compensation. So those are the respiratory disorders. On the other side, the metabolic disorder, we have the metabolic acidosis. If it's acidosis, we know it's pH is less than 7.35. It's metabolic. Then the problem in the bicarb. The bicarb here is low, less than 22. And the compensation here will be respiratory. Respiratory, you want to excrete more CO2. So usually those patients have hyperventilation, like increase in the respiratory rate to try to get rid of more CO2 to compensate for the acidosis that's going on. And in the metabolic acidosis, the compensation would be again try to drop the PaCO2. So we have the Winter's formula, that's the to calculate if the compensation for the metabolic acidosis is appropriate or not. And this formula is 1.5 multiplied with the bicarb plus 8, and you give it a range plus or minus 2. Usually the expected range of the CO2, if you want this, at, like it's a trick, it's not very accurate, but PaCO2 approximately equals last two digits of the pH. So let's say the pH is 7.28 and it's metabolic acidosis, the PCO2 will drop to compensate for that, and usually the PCO2 will be the last two digits, so it will be 28. Again, if the pH is 7.30 and this metabolic acidosis, the CO2 will drop to try to compensate for the metabolic acidosis. So you can say roughly the PCO2 you can expect it around 30. That's the metabolic acidosis. Then we have the metabolic alkalosis. If it's alkalosis, we know the pH will be high, more than 7.45. And if it's metabolic, we know the problem is in the bicarb, and the bicarb here is elevated. The respiratory compensation will be hypoventilation, which means to decrease the respiratory rate to try to keep more CO2 to try to compensate for the alkalosis, because again, CO2 is an acid, right? And we have here, this is the formula for the compensation according to the PCO2, or roughly you can say everyone increase in the CO2 within HCO3, sorry, bicarb will cause increase in the CO2 zero point 0.5 to zero point 0.7 per 1 point increase in the bicarb. And usually the PCO2, if it's compensation, it will not exceed the 55 range. Why? Because after that you start to get hypoxia. So those are the compensation formulas. We'll talk through them one by one with each disorder. Let's start with the respiratory acidosis. We know acidosis, then the pH is less than 7.35. And if it's respiratory, then the problem is in the CO2. So the CO2 will be elevated above the normal range, so it will be above 45, right? So here you're having hypoventilation that's causing CO2 retention. Why you're having hypoventilation, we'll go through the reasons or the different etiologies that can cause hypoventilation and CO2 retention, but we can divide it to peripheral cause and central cause. We'll talk about them shortly. And the compensation to respiratory acidosis would be metabolic alkalosis, right? That's the compensation. Metabolic alkalosis, then you want to retain more bicarb. How much bicarb you retain? Again, the renal compensation is slow. That's why we have acute and we have chronic. So in the acute phase, each increase in 10 points of CO2 will retain bicarb or increase the bicarb by 1. And if it's chronic, it will be 3.5. So again, the compensation in by the retention of the HCO3 would be 1 to 10. And if it's acute and if it's chronic, would be 3.5 to 10. Again, the main etiology of the respiratory acidosis is hypoventilation. and we have different scenarios what could be causing hypoventilation between peripheral causes and central causes. So central causes, usually it's seen as depression. In other words, it's decrease in the drive, the respiratory drive. You can see this in different scenarios between opioid overdose, which is the most common acute cause, benzotoxicity, brainstem stroke, head trauma, anesthesia, hypothyroidism, obesity, hypoventilation syndrome. And the key features here depends on the etiology. So if it's hypothyroidism, you're going to check the TSH. If it's benzo or opioid intoxication, you can find the pinpoint pupil. You can do toxicology screen. You can assess the patient neurologically, the alert, if the patient is alert, voice, pain. If the patient unresponsive, you can calculate the GCS. All these different clinical signs and symptoms depends on the exact etiology. So this is the central cause. Peripheral cause coming from the lung, whether the airway or it's a parenchymal lung disease. The most common chronic cause would be COPD exacerbation, but also you can see it in severe asthma, pneumonia, ARDS, pulmonary edema, if there is foreign body obstruction or laryngeal spasm. And here again, the key features depends on the etiology. So you can get FEV1 over FVC ratio, spirometry or PFT, chest X-ray, sputum culture, PEEP compliance or vent. If you have decrease in the compliance, then you'll have high PEEP. You can see that on ventilation that indicate you have some kind of ARDS or pneumonia or some kind of obstruction, right? So this is the second cause of hypoventilation. Then another peripheral one, or could be either central, could be neuromuscular failure, like GBS, MG, ALS, phrenic nerve palsy, botulism, organophosphate, poisoning, and all that. And some clinical signs and symptoms that can direct you in this way, if you see the NIF more than negative 25 centimeter water, which is a pressure. So what's the NIF? So during inspiration, that's just a brief explanation of the NIF. During the inspiration, we have something called negative inspiratory pressure or force, negative inspiratory force or pressure, which means during inspiration, you want the air to go from outside the lung to inside the lung. So it's mainly suctioning, right? So you need to have negative pressure inside and positive pressure outside to be able to do the suctioning or to get the air inside. And the NIF is just measure how much negative pressure is inside. So usually the higher the negative pressure, the better. So the normal range is between negative 60 to negative 100. So it's in this range. If the NIF is less than this, or sorry, more than this, so you are moving towards the zero, that's worse. So if it's negative 25 or more, that means you're heading to the right direction, not heading to the right direction. So if the NIF is heading this way, this is normal. So if it's negative 70, negative 80, negative 90, that's good. But if it's negative 50, negative 40, negative 25, the more you are heading toward the zero, that's a bad sign that you don't have enough negative force to be able to do an inspiration, and you need to consider intubation for these patients because they are not able to breathe by themselves. Another factor can be FVC if it's less than 15 milliliter per kilogram, or sometimes you can do nerve conduction studies if you're suspecting GPS or some nerve conduction pathology. The next etiology that can cause respiratory acidosis would be chest wall or mechanical pathology like flared chest, tension pneumothorax, kephaloscoliosis, burns, pleural effusion, abdominal compartment syndrome. All these can cause hypoventilation and respiratory acidosis. And again, we're looking for different signs and symptoms to be able to direct us this way. And sometimes it's iatrogenic. And iatrogenic, usually those patients who are on mechanical ventilation or having excessive sedation or prolonged neuromuscular blockade. And some signs and symptoms you can look for between the ventilator waveform. So if you are looking at the ventilator, you'll see different waveform that represent the pressure, the flow, the volume. So you can detect if there's any lung pathology causing changes in these different factors. Or the sedation scoring system, the RASS, which is stands for or a clinical sign or predictor for agitation. So you have different range between +4 to -5. If someone is scoring +4, that's mean they are so aggressive, they are combative. If someone is scoring -5, that means they are in deep sedation. Usually, if we are sedating someone like propofol or ketamine or Presidex or any sedative to keep them in mechanical ventilation, we are trying to target agitation level between 0 to -1, which is they're semi-alert, they are calm, all that kind of stuff. If you are giving them, if their RASS score is like -3, -4, -5, that means you are giving too much sedation. Too much sedation can be the cause for the hypoventilation and the respiratory acidosis. Another thing with the paralytics, especially, it's called train of four, or as abbreviation is called TOF. And just to simplify this, this is a clinical test, and it answers a question if I'm giving too much paralytic and causing too much neuromuscular blockade or not. So the way it works, they come to one of the preferred nerves. Usually, it's the ulnar nerve, and the neurologists conduct or give the nerve four different electrical pulses: one, two, three, four. Then they look at the nerve endings of this exact nerve, like looking at the thumb, for example, and see how much of those four different electrical pulses got conducted to the end of the nerve. If you have four pulses that all delivered at the end, that means you have very weak paralytic effect that's barely um, blocking the nerve conduction. If you conducted only two out of the four, that means you are giving adequate neuroblockade. If you don't get anything at the end of the nerve, that means you are giving too much of neuromuscular blockade, and that means that can be the cause causing the hypoventilation and the respiratory acidosis. In that case, you need to decrease um, the dose of the paralytic. So these are different scenarios for possible etiologies that can cause hypoventilation and respiratory acidosis. And the treatment usually depends on the etiology, right? And this is the whole point. You're trying to find why the patient is having this kind of acidosis to be able to treat it. So we'll just read the cause, right? So I'm not gonna go in details, but this is just a nice summary of each cause and how to treat it. So if you have opioid or benzo overdose, if it's opioid, you will give naloxone. If it's benzo, you can give flumazenil. And here you are targeting respiratory rate more than 10. Again, remember those patients having hypoventilation, so the respiratory rate is low, so probably it's below 10. So when you are treating, you are trying to target respiratory rate at least above 10 and the SpO2 above 94. If the hypoventilation because of acute asthma or COPD, you can start them on BiPAP, and BiPAP, it has the two components, the IPAP and EPAP. You can give bronchodilators, steroids, and sometimes oxygen to target SpO2 between 88 to 92. If there's any other cause causing severe respiratory failure, you can consider ET tube and mechanical ventilation and start them on usually respiratory between 12 to 16 and tidal volume 6 to 8 milliliter per kilogram. And here we are using the ideal body weight. And you try to use minimal sedation because, again, sedation can cause hypoventilation and decrease the respiratory rate by itself. And here you are trying to correct the acidosis. You are targeting pH more than 7.25 and try to decrease the CO2. That's the main problem here, right? If it's chronic issue like COPD or obesity hypoventilation syndrome, sometimes they need nighttime BiPAP or CPAP, sometimes bronchodilators, oxygen, weight loss, all that, right? And here's a really important thing in the chronic form, you are not trying to cause rapid CO2 normalization because this can cause another metabolic disorder or acid-base disorder called post-hypercapnic metabolic alkalosis. And the thing here that you have chronic increase in the CO2, right? Someone with COPD, for example, they have chronic retention of CO2. And the compensation to the increase in the CO2 will be increase in the bicarb as a compensation. So if you're coming to a chronic COPD patient and you're trying to decrease the CO2 rapidly, you'll correct the CO2, but you'll leave the bicarb by itself elevated, so this will cause metabolic alkalosis, what we call post-hypercapnic metabolic acidosis, and this is the mechanism, right? So this is the respiratory acidosis. Again, it's mainly hypoventilation issue causing CO2 retention. And the main thing is trying to figure out why this patient is breathing slow. Is it CNS problem? Is it the lung? Is it the chest? It's neuromuscular. Is it iatrogenic if the patient is mechanically ventilated or sedated, or they're receiving prolonged neuromuscular blockade? And according to the etiology, you treat, right? So that's number one. Number two will be respiratory alkalosis. So respiratory alkalosis, it's mainly you have, if it's alkalosis, then you have pH more than 7.45. And if it's respiratory, then you have PaCO2 that's low because again, PaCO2 is acid. So if you have low PCO2, that means you are having alkalosis. And the compensation to respiratory alkalosis will be metabolic acidosis. Metabolic, that means HCO3. Acidosis, that means you are trying to get rid of the HCO3 to decrease it, right? So again, here is the opposite of the respiratory acidosis. We said we have hypoventilation causing CO2 retention. Here is the opposite. You have hyperventilation, which means you are breathing very fast. And if you are breathing very fast, you are getting rid of a lot of CO2. And that's the main reason for the respiratory alkalosis. Why you are breathing really fast, why the respiratory rate is high. You can see this in different scenarios. Sometimes it's a systemic sign of sepsis. Sometimes it's response to hypoxia, or sometimes it's CNS problem or even an anxiety. And again, here we have decrease in the CO2, so the compensation would be metabolic acidosis. Metabolic acidosis by decreasing the bicarb. And as we agreed that the renal compensation is usually slow. So we have acute phase and we have chronic phase. So if you decrease the CO2 by 10 and you are in the acute setting, that the kidney will be able to decrease the bicarb by just 2 points. But if it's chronic and you give the kidney more time to compensate, it will be able to decrease the bicarb 5 points for every 10 decrease in the CO2. So again, in the acute setting and in the chronic setting, acute, you decrease the bicarb by 2 for every 10 decrease in the CO2. In the chronic setting, you decrease the bicarb by -5 or 5 points for each 10 decrease in the CO2. And again, remember, renal compensation needs time, so it needs usually 2 to 3 days. And the minimum bicarb that you can compensate to or reach is 15. So if you are starting with, let's say, that's just an example, CO2 is low, right? So let's say it's below 35, let's say it's 28. Then you have respiratory alkalosis. You start with bicarb, let's say 24. By day one, it will be 20, for example. By day 2 or 3, it can reach only 15. It will not drop below 15 because after that you can cause severe metabolic acidosis. So the kidney trying to not overcorrect. So usually if we're the kidney decreasing the bicarb as a compensation to respiratory alkalosis, it doesn't drop the bicarb more than less than 15. And we'll go through the different etiologies that can cause respiratory alkalosis. Again, remember that in the respiratory alkalosis, you have low CO2. That means you are getting rid of a lot of CO2. That means you have high respiratory rate. That means there's hyperventilation. The reason why you are having hyperventilation, it's usually it's hypoxia driven. If someone in high altitude, they having pulmonary embolism, pneumonia, edema, interstitial lung disease, or even severe anemia, the body will try to compensate by increasing the respiratory rate. And the reason here, there is low oxygen, so you're trying to increase the respiratory rate to increase this oxygen. So yeah, it works as a compensation to increase the oxygen or the hypoxemia, but also this cause a lot of CO2 excretion, so you get low CO2 in return. So any big etiology that will cause hypoxemia will increase the respiratory rate as a compensation, which will, as a side effect, will decrease the CO2, causing respiratory alkalosis. And here, the clues or the investigations depends on the um, etiology. So if you are suspecting PE, you can get D-dimer or CTPA, the CT angio for PE, or to get chest X-ray, echo, hemoglobin and reticulocytes if you are suspecting severe acute anemia, SpO2, PO2, right? So that's the number one. Number two, if it can be CNS or central stimulation. Again, remember that the respiratory center in the brain stem. So any CNS stimulation can increase the respiratory rate. And actually, anxiety and panic disorder is the most common cause, but sometimes it can be response to pain, to fever, to sepsis, to CNS disease like stroke, meningitis, tumor, or even sometimes salicylate toxicity or hepatic encephalopathy. So usually those patients, usually if I am having a patient that's having respiratory alkalosis, usually I try to look for pain and an anxiety first. Those are the two things I usually look for. If the patient pain is well controlled, if the patient is anxious or not. But don't just rely or attribute it to pain or anxiety. If you are suspecting sepsis or something else, or that the patient is hepatic um, or having hepatic cirrhosis, sometimes you need more investigation. So if you're suspecting sepsis, you can get blood cultures or lactate ammonia. If you're suspecting hepatic encephalopathy, if you are suspecting salicylate toxicity, you can get salicylate level. Sometimes it can be normal in pregnancy in response to progesterone. So if the patient is in the reproductive age, you can get HCG level. And again, sometimes it can be iatrogenic or mechanical. like patients on mechanical ventilation. And remember, in mechanical ventilation, in a lot of cases, you control the respiratory rate and the tidal volume for those patients. So sometimes you can have high respiratory rate for the patient. You can be setting them at respiratory rate, let's say at 18 respiratory rate. So if they're having respiratory alkalosis and their respiratory rate is that you are setting on the vent is high, sometimes all what you need to do is just decrease the respiratory rate. So instead of 18, you can make it 16, 14, or 12. So you can play with the ventilator parameters, but also sometimes it can be medication or drug intoxication like salicylate overdose. So if you're having a patient that's young, maybe they are taking too much aspirin or salicylate, sometimes you need to get salicylate level or drug history on these patients. The symptoms of acute alkalosis is usually between two things. So remember, acidosis cause increase in the ionized calcium, alkalosis cause decrease in the ionized calcium. So if you're having severe acute alkalosis, that can decrease the ionized calcium, which can cause tetany or sometimes seizures or sometimes some kind of spasming. The other thing, remember that the increase in the CO2 increase the cerebral perfusion. So the opposite is true. If you have decrease in the CO2, sometimes you have cerebral vasoconstriction. And the cerebral vasoconstriction sometimes can cause lightheadedness, presyncope, or even seizures, or more serious side effects. And again, here the treatment is to treat the underlying cause. So if it's an anxiety or panic, you can give medication for that. You can do reassurance, the rebreathing bag. You can consider benzos. If it's hypoxia driven, you need to give oxygen. If you're suspecting PE, then it will be anticoagulation or thrombolysis. If it's ventilator triggered like high respiratory rate or tidal volume, you might need to decrease that. If you are concerned about infection sepsis, then you will give antibiotic fluid resuscitation. So again, respiratory alkalosis is almost always a sign of another condition. And your rule is to find this condition to be able to treat it. So respiratory alkalosis is usually not a primary disease, right? And the most common cause in hospital is an anxiety. As I said, if I am having a patient, I see it a lot of times in the ICU, especially, and I get a VBG on the patient and they having respiratory alkalosis. Number one, what I look for is an anxiety and pain. So always look for the underlying etiology, but also don't just blame it on an anxiety or pain. You need to consider more serious etiologies like PE or sepsis or CNS pathology before attributing that to an anxiety.